Okay, good morning. It's Colin Talbot again, and today I'm joined by Cairney and Emily St Denny, both from the University of Stirling. We're going to structure the discussion today around their new book that's just come out, which is Why Isn't Government Policy More Preventive? Which seems incredibly appropriate in the current context. And there's a major chapter in there about public health, which is also very relevant. So I want to start off by asking Emily and Paul to just outline the broad argument in their book without reference to the crisis at the moment. We'll come back to that in a minute. So which of you wants to go first? Emily?
Yeah, I'll give it an overview. I think what's useful about the book in particular is that it's relevant, crisis or not. So effectively, we set out to investigate why, despite frequent claims that prevention is better than cure and preventive action, early intervention is the most effective way of stemming complex health and social problems, very few governments actually ever deliver on these massive ambitions. That was the puzzle. So effectively, in terms of the theoretical outlook, we questioned what prevention might mean in policymaking terms, and we argue that it is used to represent two things. One, a type of policy, one in which the government intervenes early in order to stave off problems or to stop them getting worse. But it also refers to a sense of how policy should be made. So a policy-making principle. And here we've managed to sort of tell a story of a modern way of making policy. So it's associated with modern policy making, joined up policy making, and sort of holistic overviews. There's a really big understanding that in order to prevent these complex social problems, you cannot act in silos, you have to act in a joined up manner. So that's what we noticed in terms of what prevention might mean in the rhetorics and the communication of these types of agendas. So after that, we thought, well, what are the challenges with making preventive policy? So the book has lots of chapters that are empirical. We compare the UK to Scotland across a number of sectors, including public health, but also social policy and criminal justice, to see whether or not there might be similarities and differences. And what we find is that while there are differences in the way that the two different regions deal with certain issues, there's a great deal of similarity that seem to be generic to making preventive policy. And that has to do with the ambiguity, the sense that policymakers may not actually know what prevention means. They think it's a good idea. It's a great idiom, you know, an apple a day keeps the doctor away. But when you get into it, it becomes very difficult to understand how you might deliver that. The second problem is complexity, which is that in order to make the changes that you want to see, the preventive outcomes that you want to set in, you are dealing with a system that you only fathom a part of and can only fathom a part of because of the limits to your rationality, the limits to your time, and the pressure of other priorities. And the third thing is that effectively making policy based on good sense, or effectively right now evidence-based policy making is kind of the paradigm for addressing these complex problems, isn't as simple as it looks. Effectively, there is a great deal of political decision making that still has to take part in the democratic process that policymaking might entail. So those are the three sort of big limits that we found and that we explore empirically in the book.
Thank you. Paul, did you want to add?
Yeah, so I mean, I think we were trying to make the book as practical as it could be. You know, I mean, it is as theoretical as you would expect academic books to be, but we were trying to work out how people could learn from the kinds of things we were looking at. And I think one of the things we were trying to encourage was to not identify a kind of too simple explanation in terms of a failure to take forward this agenda. That I think that there could be this potential for there to be a real kind of self-reinforcing sense of optimism and failure as each government comes in, thinks that the problem was the low commitment of its predecessor, and then make all sorts of commitments and then fail again. And I think we're trying to encourage governments to avoid that way of thinking, to think that the obstacles we identify they're ever present. You know, they're not associated with levels of high or low commitment, although high commitment would help, and they're not associated with particular governments. You know, they would all face it. So that was kind of a way of encouraging, governments not to essentially say, we will do this prevention agenda better than our predecessors. I think that essentially they'd be setting themselves up for failure if they did that.
That's very interesting. I also liked in the book your use of an approach originally developed by Christopher Hood called Tools of Government, which tries to examine the toolbox of government in terms of the sorts of things that it can do, which I think is one of the problems with a lot of policy analysis. It doesn't distinguish between the different tools. So I wonder if you could just say something about that.
Yeah, so I think it's a good way of setting up the sense that you could have the same rhetorical commitment to prevention, early intervention, but the tools you use could really signal your substantive commitment. So I think we were trying to sort of think of what would a maximal commitment be compared to a medial or a minimal. And the maximal would be a big focus on redistribution. So, you know, taxing and spending to redistribute income and wealth, because, you know, most studies of inequalities in, you know, health and education and such like suggest that you know, that the kind of the biggest instrument to use would be a redistributed one. Then at the other end, you have, I think, what you know, Christopher Hood would call nodality, which is information sharing. So they make a commitment to prevention. And their role is to share information and encourage learning between other authorities. And that's, you know, that's at the other end of the scale. That is a commitment to help people learn, but not take responsibility for the outcomes, compared to a commitment to have a major state investment and redistribution of resources and maintenance of high levels of public services. You know, so I think prevention could mean any of those things. So without a focus on the tools or the instruments they use, we wouldn't really get a sense of how committed they are in practice.
Okay, thanks, Emily. Did you want to add to that?
No, I think that what's useful is the comparative dimension as well. So even though we focus on the UK and Scotland, there are generic lessons about the challenges of making prevention. And then I suppose there's one exciting aspect is kind of assessing the extent to which prevention and preventive policy making can function and which instruments might work better across different sectors that we would usually think of.
Okay, thanks. It might be worth me just explaining for our viewers that Christopher Hood's model originally broke down the tools of government into 4 areas, which was nodality, which was the government's ability to collect and disseminate information, which is critically crucial to most policy making decisions. I mean, just to take a health example, not related to COVID, but back in the late 1980s, early 1990s, the British national health systems didn't collect ethnic data about patients, and as a result, certain ethnicities who had particular health problems, like the Chinese community, got missed out completely. So they simply didn't figure in the health agenda. So that's really important. The ones that we're more familiar with is distribution of money, collection and distribution of money, the use of authority through rules, regulations and laws, and of course organising people to actually do stuff. And those 4 boxes, if you like, or compartments in the toolbox are really useful, particularly, I think, as Emily just said, for comparative purposes, because some governments use a lot more regulation and authority, like, let's say, the Japanese government in the 1970s or other developmental states. Some rely much more on money and organisation, like the social democratic Nordic states, for example. So it's quite a useful way of trying to identify where the real differences are. I wonder if we could move on to specifically the public health example. Public health has obviously come massively to the fore in the current crisis, but before we talk about COVID specifically, I just want to explore the chapter that you have in the book about public health, because it's the one that most usually gets mentioned when people talk about preventive policies.
Yeah, so I mean, I think probably the first thing we should point out is that in, you know, prevention work, there's a big distinction between trying to prevent the spread of infectious disease, which is what everyone's focusing on just now, and trying to prevent, you know, an equivalent pandemic of non-communicable diseases. So those would be, you know, things like heart disease, cancers, diabetes, and that's primarily the focus of the book, because in that sense, the prevention agenda on health and public health is a long-term agenda to improve population health, through things like changes in behaviour, in relation to smoking and drinking and exercise, and a much broader agenda on environmental conditions and rewarding work and such like. So there's almost nothing in there about the prevention of infectious disease. I think partly because a lot of that, I guess, was taken for granted. That it was notionally a good thing that's done routinely by public health agencies, whereas the prevention of non-communicable disease was a much harder sell. It involves much more contentious choices about individual behaviour. I mean, to be honest, nothing like the discussion now about restrictions on behaviour. But but at the time, these seemed like big issues about should you try and stop people less, or should you provide a more support element? Those are those kind of issues mostly discussed.
Yeah, Emily, did you want to add to that?
What I think is useful about looking at public health, and the reason why we focused a lot on it, and there is also a chapter on mental health in particular, is that it is often used as the exemplar for prevention, because there is such a set-in notion of what universal population level prevention is in public health, such as vaccinations, population level, universal, accessible vaccinations, which then carries over into a lot of other sectors. So for example, the criminal justice chapter looks at the importing, I suppose, of a discourse of public health prevention into violence reduction, which we saw developed in Glasgow. So it's useful because it sets an exemplar and it tells you what people sort of expect prevention to look like, and then explains how that might not be possible in other type of, like Paul says, either non-infectious diseases or complex social problems.
Yeah, I think that point about non-infectious diseases is really interesting, and how societal norms have changed to allow some policy interventions which would have been unthinkable before. So if we think about smoking restrictions that have been introduced in a number of countries on public smoking and so on, certainly 20, 30 years ago, that would have seemed to be well outside the so-called Overton window of policy possibilities. And you have a bit of a discussion about that, I think, in the book, about how sometimes these opportunities present themselves.
Yeah, so I mean, I think to some extent we're setting up the example of tobacco control as the relative success story here, because you're talking about, I mean, I know that kind of the phrase paradigm change is kind of overused, but this is a kind of clear example where there's been a clear paradigm shift in terms of the state's role in trying to prevent smoking. So I think it was, in the 80s, it did seem, I say this to my students, if we were, when I was seeing my students, that, if we were in the room in the 80s, half of us would be smoking as we were talking. It just seems like a different world. So we were kind of setting up what had to happen for that change to happen. And it was, a kind of reinforcing cumulative effect of, differences in social attitudes, differences in the economic return to tobacco, and all these things reinforced by incremental changes to smoking controls, increases in taxes, gradual shifts towards warnings on packaging and towards reducing branding. But, a really kind of remarkably slow, gradual process in which the adoption of one instrument makes the adoption of another slightly more acceptable sounding. I mean, I think the one for me that I think for a lot of people, the ban on smoking in public places was the one that just seemed like it's signaled an entire shift in approach. But the one for me is to regulate smoking within cars in front of children, because that is suddenly the state telling parents how to look after their children as well. And it just seemed like, so different from a kind of much more liberal approach of kind of civil liberties that happened in the 80s. So that's a kind of standard for what can happen over the long term. it doesn't happen so much with a kind of broader prevention agenda that's kind of harder to sort of put your finger on.
Yeah. Did you want to add to that, Emily?
No, I mean, I think it's useful, again, to look at this in terms of the challenges that policymakers face, because effectively, like Paul says, these are extremely long timescapes that are completely contrary to the short electoral cycles. So if effectively we're talking about windows of opportunity for change, there's two types of windows. There's the ones that you get to say that you're going to change things, usually campaigns, and then just when you're elected. And then there's the window of opportunity for introducing change, and those may not be during the time that you're in power. So there's a complete mismatch in the timescape of prevention and the political cycles that we know.
Yeah, okay, thanks. Okay, can we turn to the crisis of the day, which is the COVID-19 pandemic. And I think it's quite interesting that the response, certainly in health terms, is being led by public health authorities, which suggests that the lead in this is preventive rather than reactive and curative, particularly as there isn't a cure for this particular virus at the moment. So I wondered if you could say something about how you see what's been going on, and maybe if we can get onto if there are any major differences between the Scottish Government and the UK Government in the way in which they've reacted to this and who they've given the lead to on the health side. Emily, did you want to kick off on that one?
Yeah, absolutely. So I think what's useful here is, again, when this crisis emerged, health is really the poster child for prevention. It's a system in which there are agencies in place, there are very large and professionalized networks of actors who are versed in epidemiology and who normally know how to tackle this. So effectively, of all the types of crises to emerge, a public health one normally would be the poster child for getting prevention done quite well, especially if it's in the context of infectious diseases, as opposed to perhaps more complex, non-communicable diseases. So what's interesting here is perhaps that you've had sort of waves, I suppose, of perception of the types of intervention. So you had quite a long lead in when it wasn't our problem. I suppose it wasn't Europe's problem. It was a problem that was elsewhere. And so very standard approaches were used to sort of contain and control individuals perhaps presenting signs. And now we've shifted into a second phase in which we've seen the use, speaking of instruments, of a lot more authority, a lot more organization, or a lot more reorganization to deal with it. And what's interesting is that effectively a lot of people, I think, have been wondering why the response wasn't necessarily as organized as you might expect for the sector that is the poster child for prevention. So I think that was the first thing, was a bit of shock. And I think that's explained by the notion that this isn't routine policymaking. This is a crisis. This isn't vaccinating children. This, in fact, shows all of the sharp ends of prevention policymaking, even if it's in the sector where we would expect it to perhaps go the best. So there is still a great deal of uncertainty, and uncertainty really binds the hands of individuals, because you increase disagreement, you increase ambiguity. So you get a lot of voices suggesting lots of very plausible ideas for dealing with it, whether it's treatments or whether it's organization or whether it's confinement measures, but they're all speaking authoritatively, and actually it tends to muddy the water in terms of clear directions to take. So this is crisis policymaking, it's not routine policymaking, and prevention in a crisis is necessarily going to be very different. What I think is interesting is that despite early divergence in sort of problem definition, where you saw differences in the way that the UK and the Scottish Government sort of approached and defined the problem, with a much more sort of herd immunity type protection of the economy argument being made at the UK level, and a much more authoritative public health perhaps angle in the north, in Scotland, we've seen a convergence. We really quickly saw a convergence in terms of the problem definition, in terms of the regulations being adopted. And partly that's because in order for prevention to work, a lot of the problems are what we call intermestic. They're not problems that originate or exist only in your territory. They are shared. So you need to coordinate in order for population level prevention to work. And so it would be normal to expect a great deal of convergence at this point.
Yeah, if I could just say something on that before Paul comes in. I mean, it's quite interesting because work that Christopher Pollitt and I did a decade and a half or so ago looking at different functions in government comparatively across 4 different states. What we found was really interesting was that the closer you got to the sharp end, the more similarities there were between the systems. So whatever the political superstructure and culture were, we looked at 4 European countries, and we looked at 4 areas of public services. The closer you got to the actual operational end of things, the more similar they became. There were still differences, but the prisons in the UK or Holland or Finland or Sweden, which were the countries we looked at, were pretty similar in the way in which they operated. Paul, did you want to come in?
So, I mean, I suppose Emily and I were keen to make sure that people didn't expect anything about pandemics in our book, but
No.
there is something that's particularly relevant, I think. So we're continuing this work, public health, long-term public health agendas, I think they're increasingly summed up by the phrase health in all policies, and one aspect of that is this desire to address the so-called social determinants of health. So the argument, I think, in most public health professions is that by far the biggest impacts on health do not come from healthcare or the health sector. They come from economic policy. They come from, access to transport and lack of pollution and, sanitation, social and physical environments. So that's been a kind of really long-term theme that you'll find in most public health professions in most countries. And so what they tend to focus on is this idea that health sectors need to cooperate really strongly with a bunch of other sectors, join up the response. So I think those kind of ideas are really relevant because, I think, COVID is often kind of called the great leveler, anyone can get it, but it's not in terms of the huge social determinants of who has underlying health conditions that make people more vulnerable. And there are huge differences in the extent to which people can follow the social distancing guidelines according to how much income and wealth they have. If you're well off, you've got a huge garden and you probably live semi-rural and you can essentially do what you like. If you're not, you probably live in a very small place that you can't isolate from other people. And I think, those kind of themes from public health, they're not particularly highlighted just now in the crisis, but I think that they're increasingly important. So, I think even if we say that a kind of prevention agenda often doesn't get anywhere, some of the themes they identify and the problems they're trying to solve are profoundly important.
Yeah, no, I agree. And it was pretty obvious from the start that sorry, the 2 places where people were going to be most socially constrained and therefore vulnerable to the virus, which was care homes and prisons, were going to be really badly affected by this. And sure enough, it's happened very, very badly. And it goes back to the earlier discussion we were having about information, because one of the problems in the UK, at the UK level, certainly been that the information about the degree of the outbreak in infections and death rates in care homes has been neglected in terms of the published information, and we're still playing catch up on that. Okay, well, I think we need to wind up. Is there anything final you want to say before we close?
I don't know. I think in terms of, taking back the language that we use in the book, maybe what would be useful if people are interested in the book to speak about this particular situation just now and the after is this notion of a window of opportunity. These relatively rare moments when you can introduce the suggestion of change and how very difficult it is to make good on them afterwards. So I think we're about to move into maybe a sort of 3rd phase of the discussion of the crisis, which is the after, in which we can imagine a much more idealized and general discussion of what we want society to look like. And effectively the book will explain why it's unlikely that you'll wake up in a utopia when this is all over, what the constraints are on reaching those sort of aspirations.
Yeah. Paul?
Yeah, I suppose I always like this phrase, if prevention means everything, then it means nothing, and I think that's the same with the idea of a window of opportunity for change just now. I think there's a huge number of people expressing a huge number of optimistic thoughts about how the world will change for the better, and I think part of the benefit of the book is to say, that almost none of those things will happen. and there's a huge amount of competition to decide what happens next. So I think you've got I think if anyone's optimistic and he thinks that the particular social changes are inevitable, I think they're on the wrong lines. These are contested visions of the future that have to be fought for against people who will obstruct them.
Thank you. I think the book is incredibly timely, and I hope everybody rushes out not rushes out, gets on the web and buys copies of it. I think one lesson from this discussion is you two need to get writing the extra chapter for the second edition on prevention and pandemics. So I'll leave you to get on with that. Thanks very much for joining me today.
Thank
you.